Good morning, and welcome to day 2 of our virtual telehealth conference series. I'm Danielle Lauder, Director of the Northeast Telehealth Resource Center, and on behalf of the Mid-Atlantic Telehealth Resource Center and Northeast Telehealth Resource Center teams, I want to thank you all for joining us today. We have another excellent slate of speakers planned for you, starting with our keynote, Anish Chopra, and a wide variety of breakout presentations and poster sessions. For those who are new this week, I'll provide just a brief intro to the Telehealth Resource Centers. The Northeast and Mid-Atlantic TRCs, or NETRIC and MATRIC for short, are 2 of 12 regional resource centers funded by HRSA's Office for the Advancement of Telehealth under the Federal Office of Rural Health Policy. Collectively, the regional TRCs cover all 50 states, DC, and US territories in the Pacific Basin, providing technical assistance and resources to a wide variety of stakeholders looking to implement telehealth to improve access to quality care. There are also 2 national TRCs, the Center for Connected Health Policy, with focuses on the rapidly evolving telehealth policy landscape. CCHP's Executive Director, Mei Kwong, will be joining us on July 10 with the latest policy updates. And the Telehealth Technology Assessment Center provides expertise and unbiased guidance on all things digital health. The TTAC team will also be joining us on July 10 to provide a virtual technology showcase. As you might imagine, the TRCs have seen a massive increase in requests for telehealth technical assistance and resources over the past few months, and we've been amazed by the innovation and perseverance of the healthcare community in rapidly implementing and expanding telehealth to ensure access to care throughout the pandemic. And just in the past week, we've seen states throughout our regions propose rule changes and enact new rules to preserve the expansion of telehealth policy beyond the public health emergency, as well as continued efforts at the federal level to sustain many of the policy expansions currently in place under COVID-19. To quote CMS Administrator Seema Verma, the genie is certainly out of the bottle with respect to telehealth, and we don't anticipate it going back in. we can't wait to hear from today's keynote presenter, but before we begin, I'd like to give a big thanks to all of our speakers and moderators once again, with a special shout out to our HRSA Project Officer, Natasha Manzanero, who's helping moderate some of our sessions today. Also, many thanks to our AV team, industry partners, and especially to the NETRIC and MATRIC teams for all of your hard work on this event. And last but not least, many thanks to all of our attendees for spending your time with us today. And now I'll turn it over to my colleague, Dr. Kathy Wibberley, Director of the Mid-Atlantic TRC, who will introduce today's keynote. Kathy.
Good morning, and thank you, Danielle. So, as has been a tradition with our MATRC conferences, we do not read long bios, so that is available in your app, and you can click on that by just visiting Anish Chopra's profile picture, and you'll see his bio. But one of the things I do want to say about him is not only is he president of Care Journey, but he was the first US CTO. But how I have met Anish was when he was Virginia's Secretary of Technology. And what I have found from Anish is that not only is he passionate about tech, and unlike the normal tech geek, he has real passion about healthcare and about health disparities. And I think that part of him is what has been just exciting for us, and he's just been a visionary on the healthcare front. So Anish, without further ado, we will punt to you and you can share your own screen.
Well, thank you very much, Kathy, and what a pleasure to join you, obviously in a virtual model, in a great sort of analogy to the opportunity that we're seeing in healthcare service delivery. So we are practicing what we are preaching and advocating around the country. As Kathy mentioned, I have been a convert and a believer in the power of telemedicine. I'll share a story I've shared for many in the past. Probably a month or two on the job as Virginia's Secretary of Technology. It was my first role in government. I received a message from Dr. Karen Ruban at UVA and inviting me to join her and to learn a bit about what she's been doing around telemedicine service delivery. Governor Kane at the time, now Senator Kane, had taken his cabinet around a kind of a Commonwealth roadshow, and we were slated to visit Charlottesville early in our roadshow. And so when the rest of my colleagues in the cabinet were there, I visited Karen. I guess, Kathy, you must have been there too, or at least around the neighborhood. And so Dr. Ruban had been preparing a presentation for me. Now, moments before my arrival, a child born at a neighboring hospital in a more rural part of the state, the local physicians were anxious about whether she had a congenital heart issue. And that child, we was on the brink, if you will, of whether she needed surgery or not, whether there was a heart issue or not. And almost to the T, I walked in just as Dr. Ruban essentially threw away the presentation and engaged in the treatment of the patient. And in fact, the patient did need heart surgery, had successful heart surgery, but the ability to diagnose, to have that rapid consult without the distance, it would have taken way too long for them to have made that judgment in a more traditional way, saved that child's life. And I didn't need any presentation. I didn't need any more details. I knew that I had to find a way to make sure this capability scaled, not only across the Commonwealth, but as I became Chief Technology Officer, to find a thoughtful path to take it nationwide. Now, I want to share with you a bit about how the broader, bigger picture creates the conditions right now, not only amidst COVID, but even beyond that, on accelerating the adoption and use that I put in parentheses, telehealth, in that at some point we're just going to treat this as health. So what I'd love to suggest to you is that there are three trends that are coming together. I'm going to be talking through each of these trends, but in a nutshell, they are: one, we'll be opening up government data, and increasingly now by regulation, private data. Second, we're going to be connecting these data sets at the beneficiary level through these modern internet-based systems. And then last but not least, so last but not least, there's this opportunity to think about payment reforms, and that opportunity to share payment will give us a kind of an economic model for telemedicine more broadly. A little bit of background. My journey, if you will, involves three of these key steps that we'll cover in more detail over the rest of the presentation. One, when I first took office in the White House, it had been effectively illegal for the U.S. government to share detailed information about the Medicare program for commercial use. It was seen as a privacy violation for hospitals, health systems, more specifically physicians, because you could impute someone's salary if you had access to how much money Medicare was spending across the healthcare delivery system. That rule had changed, and we are now entering an era where CMS is leading the way in opening up data. Second, as I mentioned at the outset, we spent $35 billion on electronic health record sharing. We reserved a small share of that, about $60 million, for research and development. About a portion of that went to a team at Harvard, Zach Cohane and Ken Mandel, and that group very successfully hypothesized that there's this thing called the internet, and it's working in every other sector of the economy, but for whatever reason, we are failing to harness its power and potential in the healthcare sector. So they wrote a paper asking for there to be a form of iPhone App Store layer in healthcare, a white paper that resulted in a gathering that had a bunch of stakeholders to say, look, we're about to make this huge investment. Let's not miss this as an opportunity to leapfrog into the internet era. And lo and behold, a modest grant back in 2010, small app challenges, and then eventually a decade later, regulations that we'll talk more about in the course of the presentation, to say that every doctor, hospital, physician group, and health plan must have the ability to communicate on the internet using regulated standards that had their origins in that R&D grant. Last but certainly not least, the healthcare delivery system is looking to change the way we finance healthcare. And while there are plenty of opportunities to participate in Medicare ACOs or bundled payment programs, I wanted to highlight a very specific authority that was part of my life experience, which is the authority to test any intervention that has the potential to deliver quality over cost. And many of you on the line today applied for and benefited from the hundreds of projects that were awarded over the course of 2012, 13, 14. I will also note that the first graduate of this investment program, the YMCA, proposed the diabetes prevention program for funding, a $600 voucher effectively to get pre-diabetic seniors eating healthier, focusing on their activity. And with just a few years of quote unquote clinical trial experience, the actuary at CMS certified the model as delivering a 4-to-1 return on taxpayer investment, scaling the intervention nationwide. Doctors today have the ability to prescribe this prevention program, and we'll talk more about how that has implications for telehealth. I also want to highlight what I consider to be bipartisan theory of change. You know, we're in the middle of a presidential election cycle. There's not a lot we're going to say that puts the D's and the R's on the same page, but I will point out on issues of modernization and on healthcare delivery reform, there is a coalition of the willing made up of representatives in both the Democratic Party and the Republican Party who believe that in order to hit the milestone of constraining healthcare inflation to GDP plus 0, which would unlock trillions of dollars of benefit and to allow the US to reinvest those savings in economic competitiveness. By the way, both parties might disagree on how to reinvest those savings. One might focus on tax cuts, another might focus on strengthening the social safety net and investing in R&D in the industries of the future, but I'll leave that for the national discussion. This coalition of the willing, public sector, private sector, left and right, there is a thesis that we can, in fact, achieve healthcare inflation at GDP plus 0 simply by delivering better care. And by studying areas in the country where for groups of patients that are achieving or getting better care, if we could scale that across similar populations nationwide, and you do that across hundreds or thousands of micro interventions, the net effect would be a country that spends less and delivers a higher value for the dollars invested. I will note that while that's definitely true in the government-sponsored programs of Medicare and Medicaid, in the commercial space, we do acknowledge that there is a huge price issue that we have to tackle in addition to delivery system reform. But if you are in this coalition of the willing, you have a very simple thesis. By opening up data, adjusting the payment models, and personalizing consumer navigation, we have the ability to tap into our collective expertise around the country to surface and scale what works. In other words, this theory of change is not about Washington getting its act together and telling us what to do. In this theory of change, it's about us raising our hands, delivering better value for the people in our community, and to plug right into the public-private partnership models that would allow us to surface and scale those interventions nationwide. I'm going to begin with a discussion around open data, and I might spend a bit more time on open data than the other levers, just in the interests of what I believe is critical for this community to rally around. But to demonstrate the bipartisan nature of this, almost literally and figuratively, you'll hear the term blue button as an Obama administration call to action, basically a metaphor that we as individuals should have the right to push a proverbial blue colored button on a website or a mobile app to share our health information with whomever we trust. And that spirit of blue button, which had been scaling across the Medicare program, the VA program, and the DoD, we are now witnessing what the Trump administration calls, wait for it, Blue Button 2.0. They had the ability to rename the program, in fact, chose to double down, and I think purposefully. But broadly speaking, this open data movement is under the moniker of the My Healthy Data Initiative. And it has these two features. And I thought, given that we're now making public policy through tweets, nothing better than to share two sample tweets to explain what the My Healthy Data Initiative is all about. On the left, you can see the release of aggregate data. That is to say, data about how the government spends money on healthcare, making that available to the public, and more importantly for this discussion, to unlock the commercial potential of the use of the data so we can incorporate the lessons learned more rapidly in our respective practices. The Trump administration has doubled down on the release of Medicare data, which had been a priority in the Obama administration, and has extended that to releasing Medicare Advantage data, which is private insurance data that now is accessible in the public domain, as well as for the first time ever, Medicaid encounters, the TMSIS data. That was announced more recently in November of last year and is now flowing through the public channels to be available for researchers all around the country. In short, the US government over the last decade has found a way to make over 100 million linked longitudinal claims files available for dissemination, research, and use. And I believe this will accelerate our lessons learned and the opportunity to find pockets of best practice and scale them. I will also highlight that Blue Button 2.0 takes that aggregate data and applies it into the beneficiary or individual level. And I gave an example here. I work with the health system or health plan called Humana. Humana was the first at-scale production implementation of Blue Button 2.0, with a few days left in open enrollment back in 2018, December. Humana was able to introduce a simple feature. If you are shopping for a Medicare Part D plan, and my mom and dad both are on Medicare, and I can tell you they are chronically ill but healthy, touch wood, it is super annoying that when they shop for their Part D plans, they have to manually enter all the medications they're on in order to get a true comparison of estimated out-of-pocket costs. That manual reentry of the data felt redundant when sitting in their mymedicare.gov Blue Button service was all of the structured medication claims that they've been ordering all over the previous year. Humana, tapping into the Blue Button 2.0 API service, was able to quickly invite not just my parents, but thousands of people around the country when shopping for a Part D plan to securely and safely, with trust, share that information with Humana to help estimate out-of-pocket costs so they can ensure a more confident decision when making a Part D plan selection. For the economists out there, please note, the average senior spends $500 a year more on drugs because they picked the wrong plan. Blue Button 2.0 is going to be a mechanism by which we minimize the error when making individual decisions, from plan selection to PCP decisions to specialist access to whether or not they wish to access a remote monitoring or telehealth service. The manifestation of this open data movement is to fulfill another component of the Affordable Care Act, and that is to drive the value of all this data release for, quote, provider performance measurement. It has long been a CMS policy to make it easier for consumers to shop for high-value providers, high-value hospitals, high-value nursing homes, and we see a 5-star rating system in production, mostly on the facility side. As it relates to physicians, it had been, again, bipartisan policy that there should be a public-private partnership standing up to help us understand what is or is not high-value care. That remains a work in progress for the country, but I wanted to share version 1.0 and a little bit around 2.0 around where we're heading. Back in the Obama administration, when this data was released for the very first time, Wall Street Journal, New York Times, and other publications, ProPublica, they took the detailed spend information available for the first time by CMS and published physician scorecards. For the first time, the American people could see Who made the most money on Medicare? You can see I've grayed out the doctor's name, not because it's not public information, just out of respect for a forum like this. But this physician was paid $11.1 million in calendar year 2015 treating Medicare patients. Now, for those of you who are primary care doctors, you might be scratching your head. How is that physically possible? At $100 a visit, how many hours in the day are there to see patients? Well, the reality is for many specialists, including ophthalmologists, a big chunk of that spend comes in the form of pass-through costs for Part B drugs, that is to say, medications that are administered in the physician's office. In this case, $9 million of the $11 million in payment, all tied to a single category of injectable drugs. There are 3, now 4 options for a physician who's trying to help patients with one of the most stressful clinical positions, that is the risk of going blind. If your loved one is at risk of going blind, you would do anything in your power to get them the treatment they need. And the miracle of modern medicine, we now have injections that can help stall the progression of macular degeneration. Herein lies the rub. At the time, in the last several years of this discussion nationwide, the NIH published not 1, but 2 studies to say, you know what, if you take a version of a drug that's available on the market called Avastin, and you inject a little bit of that drug into the eye, you get the clinically equivalent treatment of 2 branded drugs specifically FDA approved for macular degeneration, Eylea and Lucentis. But the cost differential for these clinically equivalent drugs can range from $50 for the compounded version of Avastin to thousands of dollars per injection if you were to use Lucentis or Eylea. Guess what percentage of injections this particular ophthalmologist had used? Was it a third? No. This was 90+% high cost drugs when a $50 alternative was available. With this kind of information publicly available, if your loved one who has to pay a 20% co-insurance for Medicare Part B because they couldn't afford a Medicare supplemental plan, but they were at risk of going blind, would you want them to go to a doctor whose predilection is to put them on the highest cost drug for the same clinical outcomes? Or would you look for a physician in your neighborhood who is more likely to prescribe and inject the low cost but reasonably clinically equivalent alternative? That's Physician Scorecard 1.0, taking the cost data as is, raw, out of the CMS open data sets. CareJourney, the company that I founded in 2015, is grounded on the premise that if we could get detailed information to drill beyond the aggregate files that are published at CMS's website, if we could get underneath the hood, we could understand a patient's longitudinal journey and start to look at value-based care measures to understand what are some of the readmission rates and quality and outcomes measures that are harder to get if you simply look at the cost CMS spend database alone. How might we refine our scorecards? I've blanked the name of this orthopedic surgeon, put my name in there instead, but this is the work of CareJourney, just a bit of a mini plug about what we do for a living. How do we harness all of this open data to identify which physicians are delivering higher value care relative to their peers in a given market? This proverbial Dr. Chopra does seem to be slightly more expensive than his peers when compared against a mix and risk adjusted market average for hip and knee replacements or the major reattachments of the limb. But look deeper at the procedure hip and knee replacements except the joints, and you find that this particular Dr. Chopra does a small share of these procedures, but is considerably more expensive than the market benchmark. And so while you might like Dr. Chopra for general orthopedic surgery, if you're going in for a knee or hip replacement without the joint, you might want to think of an alternative surgeon who might be a little bit more cost effective and with minimal impact on risk adjusted mortality or hospital acquired conditions or readmission rates. So this open data movement allows me to pause and share something a little bit unprecedented. Today, the Medicare system for researchers like CareJourney or any other academic researcher or commercial researcher, data is updated in the CMS Research Cloud roughly 6 to 8 months after the date of service, which means for us to see a window in the world of telehealth utilization amidst the pandemic, which all of us are curious about, we will wait as a nation at a minimum, probably assuming Q2, that would be June 31. We would probably wait until Q1 of 2021 before we have access to this information to see what works and what didn't. CMS has done something revolutionary. Number one, this past week, they released their own preliminary statistics on the COVID population that were representing the demographic and utilization and outcome experience for Medicare patients that are hospitalized through COVID-19. But for researchers like us and others, CMS has granted us the same monthly access to help us understand a wider range of research questions, including what happened on telemedicine or telehealth utilization when all the codes have been relaxed, all the site of service rules and rural and all the things that we've been arguing about in a public policy context stand down. So we are excited that in the coming weeks, touch wood, we'll be able to run the same analyses, not waiting for next 2021, but later this fall to be able to publish what we've seen and learned in the first wave of this spike in telehealth utilization. To give you a window into what we can learn, I thought I would share the baseline statistics. We have data today through 2019 year end. And by identifying telehealth visits, either because their place of service is documented as telehealth or they use the HCPCS modifier codes, we'll obviously acknowledge that most of these services today are poorly coded, if at all. And you'll note that very few beneficiaries out of the 35 plus million fee-for-service beneficiaries, only 335,000 beneficiaries had actually had any telehealth claims filed on their behalf from 2017 to 2019. Very modest, a spend rate of a cumulative 112 million in that time. You can see below the utilization of telehealth services at the claim count level on the bottom left, and you can start to see the number of physicians and practice groups growing that are turning on the telehealth capability. This will obviously hockey stick as soon as we get to the data in Q1 and more likely Q2 of 2020. To give you a sense for sort of the utilization patterns as baseline, you'll note that the telehealth, the beneficiaries who get telehealth services, nearly half had only one claim. But there is that long tail for the other half, with some all the way out as more of a routine service with 10 plus visits. The average claim per patient, when you factor all this in, about 3 claims per patient, about $240 in spend. And for those patients, this represents about a fifth of their overall Part B spend. I will also note that when you include hospitalizations and other factors, it's still 10% of the overall cost is delivery of services through telehealth at 11%. One area that we might be able to shine a bit more light is a deeper dive on who is actually accessing these services. You might be surprised that for the beneficiaries that are getting 3 or more visits, the 64,000 of those beneficiaries who did in the year 2019, Their average age is below Medicare's retirement age of 65, and you might be scratching your head. It's important to note that Medicare for the disabled population can cover services for under the age of 65. And lo and behold, for folks who get 3 or more visits, they tend to be in that under 65 disabled category or with end-stage renal disease. About a majority of 54% actually in the disabled population or ESRD population tapping into this service. You might be wondering, what are some of these other categories? Professor Ashish Jha at Harvard, now Brown University, and his colleagues Jose Figueroa and Karen Joint wrote a groundbreaking paper that was covered in the National Academies of Medicine study on high-need, high-cost patients, re-examined the Medicare population and tried to categorize the benefits or the individuals into clinically relevant subgroups. And what they found was that a senior with a frailty condition, and they've identified several dozen codes of indications of frailty. If a senior had 2 or more of those codes in their chart, they would deem them to be a frail elder. That person represents maybe 9% of the Medicare population nationwide, but accounts for 44% of the population with avoidable spend. In other words, that sub-cohort of the population is the group we need to focus on the most if we're going to hit the national objective of bending the cost curve while delivering higher value. That's where the money is. While frail elders are 9% of the national Medicare population, they represent 20% of the beneficiaries who benefit from telemedicine. That's an interesting finding, given all the debate about the digital divide and broadband, and do folks have services, and do our frail elders that don't have sort of, iPhones at the fingertips, do they have the ability to access? And it turns out they're twice as likely to appear in this cohort of patients than they are in the overall Medicare population. The other interesting thing is telemedicine in the commercial context is often seen as this sort of service of the worried well. I can do a symptom check, I can avoid an ER visit, I can do lightweight services. Here, the HCC codes, that is this a proxy indicator of the sickness of the patient, these are off the charts sicker patients using these services. By the way, I was curious, how well is their care getting coordinated? And about a quarter of the Medicare population is in the ACO model. So too are beneficiaries who are accessing telehealth services in 2019, similarly distributed. I am anxious about, confused in a way, that it turns out the plurality of patients are actually in urban settings. What I had always believed that this was a kind of a rural site of service situation. And maybe as we'll get into the next slide, you'll start to see why. And I wasn't following in great detail all the trials and tribulations, but it might very well be that mental health may be an area that is allowable for more traditional telehealth use. You can see that the growth rate in service area, mood disorders, schizophrenia, and anxiety are the drivers of the billing. The HCPCS codes, or the services rendered, are mostly on the mental health side. And you can see that both in terms of who is billing these services, in terms of psychiatrists, clinical psychologists, licensed social workers, as much as the codes that are being billed. In general, there are 22,000 providers in the database who in 2017 to 19 provided telehealth services. They on average delivered about 23 patient encounter. They treated 23 patients using telehealth. And they on average had about 73 claims per provider, averaging about a $5,000 revenue stream. There is this sort of residual code on the far right that I point out. Obstructive sleep apnea happens to be an area that gets billed. And again, it's still early days. This picture will look completely different when we get our hands on Q1 and Q2 data. I share all of that open data to say, as we continuously learn and incorporate the learnings in our physician practices, health system, integrated delivery networks, or broadly disseminated risk-bearing clinically integrated networks, my hope is that the pathway from insight to action will shrink from the proverbial 17 years on account of having this information available. I now want to hit the other two legs of the stool. The fact that not only is the aggregate data open, and we did a bit of a deep dive on telehealth thus far, we now have the authority to share information and to do so at the beneficiary level and not as an afterthought, but at the center. We'll call this the consumer first delivery reform era. We have flipped the narrative at the nation. While we've worked for a decade on health information exchange, and we've invested a considerable amount of money digitizing doctors and hospitals, what I will point out is that our experiment with relying on those doctors and hospitals that compete vigorously in the market to throw down their arms and work together on a voluntary basis to share information didn't quite turn out in the way we had hoped. That we are flipping the narrative to say the one person in the healthcare system that is legally entitled to the access to the health information is a right enshrined in HIPAA called the patient's right of access. If a patient invokes his or her right, requesting a copy of their medical records in a form and format that is readily producible by the hospital or the doctor's office, failure to honor the request within 30 days subjects the provider to a fine. And the going rate is in about the $80,000 mark on the hospital level and thousands of dollars on the physician network level. CMS, HHS more broadly, in this case, the Office of Civil Rights is the enforcement arm, have dusted off the rule books and said, we're going to enforce the patient's rights. In addition to the policy changes, we now have a technical roadmap. Starting in 2016 or 17, the EHR vendors in a standards process called the Argonaut Project, which was sort of a coalition of the willing, focused on getting to market a FHIR-based, internet-based API standard that would allow an app in the consumer's hands to connect to the doctor's EHR, to seamlessly withdraw a copy of the records from the EHR system to the phone. That standard has now been deployed in thousands of locations across the country. If you want a running tally of how many places are live on the 2015 edition of the Meaningful Use Program, which comes out of the box with this sort of FHIR API service, for the most part, about 8 out of 10 EHR vendors chose the FHIR API standards-based approach to meet the rules. Go to the Apple Health website. Apple publishes a growing list of every clinic or hospital that is live, enabling at least one app, not the only app, but one app to connect to the physician's EHR. By the way, I put a screenshot from that Apple website, and you can see the very first name of who's live on Apple Health is Richard M. Adams of Family Foot Care of Texas. I don't know Richard M. Adams of Family Foot Care of Texas, but I venture to guess he's not the most IT rich of doctors and hospitals in the country. And yet he was able to connect to Apple Health or Schmapple Health or Frapple Health. And you can see I've put two phones in this patient's hands. There's an Android version called Common Health that I'm helping scale, all of which as infrastructure, empowering the American people. This regulation that CMS has expanded upon from the Obama era into the Trump era now makes it the rule of the road that every doctor, every hospital, and every government-sponsored health plan over the next 12 to 24 months must turn on this feature. Health plans have to not only take the claims data that they make available like Medicare does and present that to the American people, but they also have to figure out a way to open up the what I would call a clinical profile. Many health plans today collect clinical information for quality measurement or risk adjustment or care coordination. If a health plan collects clinical data from a doctor's EHR, they have to package that up in the same API so the consumer doesn't have to go running around the country to figure out where all the records are. They can go to at least one service, the plan API, in order to access as much of the data as the plan has on them to an app of their choice. Secondly, and this is critical for the functioning of our telehealth ecosystem, when you are a telehealth service provider and you want to connect your IT systems to a physician's practice, you may not rely exclusively on the consumer to connect the two systems, although that absolutely is by right available. You might want to have a more seamless turnkey operation. By 12 to 24 months, doctors and hospitals will have the ability to use a new functionality called bulk FHIR, the ability to aggregate the information sharing, not on a single patient with a single patient's username and password as the mechanism to unlock the key, but by contractual agreement, health system A, telehealth service provider B should now be able to share information on a group of patients that have accessed the telehealth service but are treated more generally by the health system. That group of patients, there should be more seamless interoperability so that both parties can share information with each other. And the bulk FHIR standard that ONC has regulated that every doctor and hospital stand up within 2 years, with the certification window starting as early as next year, that functionality will be the mechanism, in my opinion, that would enable a telehealth service provider to seamlessly connect. Note that that will not be a contraction, that will not be a right of access. That'll be a relationship born out of a contractual agreement. But I would begin drafting those contractual agreements now so you can iron out all the details about how a telehealth app connected into a health system app can exchange information using these standards and get away from bespoke custom integrations, which frustrate everybody. I recently spoke to the National Business Group on Health, and I will point out as I get to this third realm, which is we're moving from connected apps and we're going to transition from connected apps to care delivery reform. In a survey conducted by the National Business Group on Health, you can see that employers are all in on investing in telehealth services. But I refer to these as disconnected digital apps because the employer might pay for the benefit, but that has no connectivity assumptions between that benefit and the doctors that these patients trust for their routine care. That same bulk FHIR contract, in my opinion, will be central to an employer that's looking to create a care coordination system, an accountable care network. Critical to those design models are the provisions that would require those health systems in the network, those providers, to agree to enable application access to each of these telehealth service providers, especially if those providers are independent of the physicians in the network. Whether it be decision support, lifestyle coaching, diabetes care management, weight management, and the more traditional triage services. All of these virtual capabilities that are in demand on the employer side absolutely should be incorporated in an interoperability framework. Now, what's the elephant in the room? Last couple of slides, and I'm happy to take questions. Number one, it has been, up until this pandemic, a financial disincentive in our fee-for-service system to route patients towards telephonic or video consults that did not have the kind of reimbursement parity that we've been fighting for generations. I will say that one argument, and I used to share this when I was in government working to try to advance these causes, one argument is let's continue to beat up the fee-for-service system and demand the bean counters accept that a reimbursement parity would be budget neutral, which no actuary or bean counter has heretofore accepted as gospel. The big reason why this stuff doesn't scale is it comes with a price tag, according to the budget actuaries. That one path is to continue to fight to push through a fee-for-service reimbursement scheme. And it does look like with the pandemic, we will absolutely achieve some degree of a new normal where that fee-for-service system does in fact have a baseline incorporation of telehealth. But if that's the end game for those of you on this webinar, I would suggest that you'll have missed the bigger forest from the trees. What's more interesting are the growing numbers of alternative payment models that bypass fee-for-service altogether and create a much richer investment climate to incorporate telehealth into core care delivery. Perhaps most interesting to me is the national rollout of primary care first, a model that will be available to half of the American people in 2021. This model rips the Band-Aid off of fee-for-service medicine, and it pays primary care doctors who choose to participate a flat primary care visit fee adjusted for patient risk and the ability to get paid more if that patient sees them less but gets better care and outcomes. In other words, it will incentivize more remote patient monitoring for those high-risk patients. It'll incorporate incentives to bring in mental health counseling within the primary care practice, which has long been a gap in our clinical care model, and other factors that are critical to service a high-need, high-cost population in a more cost-effective way. These asset-light delivery models will scale faster, in my opinion, under primary care capitation than they will even with the fee-for-service codes and the permanent extension of CMS authorities on the area. Even more to the point, we have an opportunity to design very discrete bundles, episodes of care that build incentives for telehealth services at the outset. Dr. Karen Ruban and I, going back to my Virginia roots, we awarded Dr. Ruban a small grant, I don't know, 120 grand, I think it was, whatever the number was, back in 2008, 2009, because Governor Kane made it a priority to tackle the absurd discrepancies in preterm birth rates across the Commonwealth of Virginia. The Commonwealth of Virginia is one of the wealthiest states in our union, and yet our preterm birth rates and infant mortality rates look in many parts of Virginia like a third world country. We found a clinic, a rural clinic, federally qualified health center on the outskirts of Charlottesville, about an hour and a half north in Harrisonburg, that had the highest preterm birth rate of any region in the Commonwealth. And we knew there were patients in that community that lacked access to high-risk OBGYN services because, frankly, there hadn't been a board-certified high-risk OBGYN anywhere for miles. In fact, the closest would be Charlottesville, where UVA is. So we funded, out of the grant, the fee-for-service payments to a high-risk OB who agreed to treat these individuals who stayed in their community, went to their local federally qualified health center, and accessed the physician visit through telemedicine, telehealth. Out of the first 305 patients that we treated, we found 25% reduction in preterm birth rates, savings on unnecessary NICU admissions, making the system safer and healthier and cheaper for the American people. By the way, that project can't scale unless we've got, beyond grant funding, more traditional reimbursement for these services. Enter maternity bundles. I serve on the CMS's Healthcare Learning and Action Network Care Delivery Transformation Committee. The Healthcare Learning and Action Network has been thinking about a number of new bundle models. And the maternity bundle is one that looks to scale, hopefully nationwide, which would create the financial incentives to deliver that exact program we launched in Virginia in every state that adopts the bundle. I cannot wait to see how we incorporate all of these care delivery models into routine care, where telehealth isn't a side project or something that has to be separately negotiated in a fee-for-service world, but is built from the ground up into the delivery model. I'll end with this. Care delivery transformation that will result in healthcare inflation constrained to GDP plus zero, in a manner that delivers better outcomes as we retain and constrain cost, will only happen at the pace of trust. These rules give CMS and ONC rules give patients the power, but will patients participate? It's an open question. In today's era of privacy risk, of Cambridge Analytica, and a range of other news stories, will patients trust this new digital ecosystem, even if it means missing out on more coordinated, higher value care delivery? Rock Health, my buddies in Silicon Valley, do surveys every year. One positive note, while we've talked about Apple, Google, and all the other big tech firms that might come running in to build apps, and I love all of them, but I love everybody. But note at the bottom of the trust list are tech companies. 11% of the consumers surveyed by Rock Health said they would trust a tech company to help manage their data sharing. Overwhelmingly, it's your doctor, and dare I say, even your insurance company, who patients trust. So an important factor is not to wait for the cavalry in Silicon Valley to come save healthcare, but it's for healthcare itself to create the trusted on-ramps for patients to engage in the kind of collaborative care models and care coordination efforts that make sure we route patients with the kind of decision support that they need to know when to access a particular service, telehealth or otherwise. We have this opportunity, and it will incorporate not just your clinical information or your claims information, but you'll be able to access the pricing data as Congress and the administration fight back all of the industry lobbyists who've tried to keep us in the dark all these years on these negotiated rates. With that, Kathy, I will pause my formal remarks and take an opportunity for questions, if that would be helpful.
Yeah, great. Thank you so much, Anish. And it was just fascinating learning about, what has transpired even in the last 2 years with technology and with this whole digital piece. So our first question is, does this coalition include those working on bridging the digital divide, especially a rural divide? Rural regions stand to benefit most from telehealth, but creating broadband and digital literacy infrastructure falls outside healthcare funding and payment.
Yes, I'm very sensitive to this subject. And I would hate to say that for those of us in the coalition who want to solve this problem, have to be a bit of systems integrators. So there are three things that have to come together. One, we have to create the economic case to make the infrastructure investments even in these rural areas. And I believe the economic case is not tied to the telecommunications bill. The economic case is tied to reducing unnecessary spend in rural America. How many folks in rural America are getting their routine annual wellness visits? Far fewer than they do in the urban settings. How many are getting flu shots? Far fewer than in the urban settings. How often do they leave a hospital, go home, and get access to a transitional care service provided by their primary care doctor? Far fewer than in the urban settings. So what you need to do as a systems integrator is to harness the economic benefits that will come from delivering better care. That means recruiting doctors and hospitals in rural America to sign up for alternative payment models, and then to incorporate into those models the investments necessary in infrastructure so that we can extend broadband access in addition to what we get out of the federal grants, linked to a delivery system that's incentivized to use the programs. So that does put a little bit of a burden on you. I will say the FCC $100 million connected care pilot, which will launch soon, focused on veterans and low-income Americans, will be your ideal test bed on which to jump into these programs. But my first and number one priority would be, if you live in rural America, please recruit your doctors and hospitals to join in alternative payment models. It will reward them for delivering more coordinated, better care, and will naturally incentivize the use of telehealth services, even into broadband to the home.
Fantastic. What about privacy transformations and discrimination address as we scale to population then planetary health?
I love this question because it's an active debate. I do co-chair the Karen Alliance, and I failed to share that update in my remarks, and I apologize for that. The Karen Alliance was founded by all the national coordinators, David Brailer, David Blumenthal, and then on the more policy-oriented side, Governor Levitt and myself. So 2 Democrats, 2 Republican administration appointees. And we've recruited a multi-stakeholder coalition over the last 2 years to find a way to get the industry to develop a privacy code of conduct that released in May of last year. So we're about a year in on the Karen Code of Conduct, CARIN Code of Conduct, and feel free to Google that. I will note that the Karen Code of Conduct today allows, actually extends beyond HIPAA, Kathy. That means that not only does the app developer who is offering you a service to share your data agreeing to keep essentially the privacy and security, be transparent with you about what they intend to do on the use of the data, we require app developers to disclose, are they de-identifying your data and selling it? I would hesitate to note, Kathy, if we require doctors and hospitals and health plans to disclose whether they are selling your data, you would be shocked to see what's happening in healthcare today. Privacy protections for those who sign on to the Karen Code will be stronger than what you get in HIPAA in the current healthcare delivery system.
Great, thank you. Where can we learn more about bulk fire that you just discussed?
Yes. What I would suggest is, for those of you who are technical in nature, the website smarthealthit.org is the repository for all of the documentation, the webinars, the background. That is the byproduct of the R&D grants that we made available to professors Zach Cohane and Ken Mandel at Harvard. They were the originators of the bulk fire specification, and they continue to hold roundtables and publish white papers on why and how anyone can participate. And Kathy, I would clearly recommend, if anybody wants to dive into that directly, I hope they can reach you, Kathy, and then they can find me. Anyone can find me on LinkedIn or Twitter, and I'm trying to be as accessible as possible. I would love to accelerate the adoption and use of bulk fire.
Fantastic. And we have time for one more question. Are we not missing a huge opportunity at this pivot point where patching new technologies and new applications of aggregated data using computational algorithms into an antiquated sickness care non-system model? Would not a Kuhnian transformation new model of true healthcare be more effective?
So this fancy words, Kathy, these fancy words really speak to my comment about alternative payment models. If the incentive is to deliver better care at lower cost, then you would apply all of these. Let me take a step back. What is the highest ROI use of artificial intelligence in healthcare today? Is it triaging patients based on their clinical risk for new interventions? No, it's boosting the billing and reimbursement strategies in fee-for-service healthcare. It's a back office resource. The minute you flip the paradigm from revenue cycle optimization into value-based care, by the way, I also acknowledge there's a revenue cycle problem and data use there as well on risk adjustment. Leaving aside, at least the incentives in value-based care are to accurately document the patient's risk and to route them to interventions that treat those risks in a better way. So if you want to activate clinical use cases for these modern tools, you would want to double down on alternative payment models, as I would.
Fantastic. Thank you. Thank you for your time, Anish. And we are out for this plenary session. However, we do invite you to join Anish in a Zoom room if you'd like to continue a little bit more robust discussion with a smaller group. And so we will be posting the Zoom room link. It's already been posted into the Q&A chat function in your app. Anish will just stay put where he is. For those of you who will not be joining us, we would love for you to rate this session. If you're in your app, just go to the session rating feature. And thank you all for joining us. And we very much appreciate your time and appreciate Anish's time. So for those of you who want to join us in the Zoom room, please join us now.
Thank you, Kathy.
Thank you so much.